always going to see how well, I guess, the webcast is working and our emails are working, but Kathy can keep me informed on that. But I'm going to go ahead and call to order the Quarterly New Mexico Department of Health, Facilities, and Local Community Program Governing Board. And today we're meeting at New Mexico Behavioral Health Institute. We're being hosted graciously here by Troy Jones and his team. Have done a fantastic job. Looks fantastic. And it's Thursday, October 17th, 10 in the morning. I'll go through some logistics in a minute, but first I'll go around as we do each time and we'll see who's present and see if we have a quorum. Good morning, Thomas. Good morning. So I think I'll start to my right with Cabinet Secretary.
Loretta Ward, Secretary of Health.
Leonard Tapia, ASD Director.
Louis Trujillo, Office of Facilities Management.
Mike Mulligan, Administrative Service Division.
Good morning, everyone. Troy Jones, welcome to NMDOH, NMDOH Director.
Kathy Rock, PhD, Deputy Director.
Jeremy Everell, Fort Baird Medical Center, Administrator.
Antoinette Grego with the Office of the Secretary.
Kathy Thompson, Office of Facilities Management.
Jeff Esquivel, Application Support.
Tomas Lopez with the New Mexico Public Education Department.
Michael Gutierrez, Turquoise Life Hospital Administrator.
Jamie Davies, New Mexico Rehab Center.
John Hellebuss, Los Lunas Community Program.
Lori Montgomery, Administrator, New Mexico State Veterans Home.
Lynn Gallagher, Deputy Secretary, Department of Health.
Gino Rinaldi, Secretary of Aging Long-Term Services.
And Brad McGrath. I think, Kathy, members absent, I think it's Charles from Sequoia.
Charles Vito, Secretary Hale, Gail Nash, Daphne Rude Hopkins, and Gabby Sanchez Sandoval.
All right, only a couple of those are voting members, but I know Gabrielle will be here, I believe. I think she's on her way right now. Probably Charles is also. All right, and do we have anybody, is Ruby Ann on the phone, or is she connected to us? Or?
She was going to dial in. She has the packet and the number.
All right, so we may have Ruby Ann also. So we do have, we have established a quorum for the meeting today. I want to mention just a couple logistics. Again, I know some of you had a chance, Troy, some people had a chance to do a tour or started a tour. To do a tour of your whole campus would take a couple of days, I think, probably.
We're actually going to offer a tour after the close. There's going to be some food provided, and then after that, do a tour of APD. We'll go through the old meadows just so people can see where these residents came from, and then go into forensics APD, and probably wrap it up with our adolescent unit. And I have staff very excited about the Secretary being here to do that.
That'll be around 12 o'clock, I think.
Probably 12:30.
12. And how many people are interested in going on that tour at 12 o'clock?
Oh, is that the tour of the lunchroom?
Yeah.
Because it looks nice.
Might be. Well, forensics is quite a place to see all by itself. We have a big campus here. You'd be surprised how large this campus is and how diverse the patient population is in this campus. So that's great. So hopefully some people will have the opportunity to do that. Later on, I can actually mention it here on our next item, the approval of the agenda. We do have one change to the agenda. We left off, we have adjournment there, but actually we'll be adjourning to closed session as we do each time. And then we'll be adjourning back into open session to end the meeting. But so at the end there, we're on 5 where it says adjournment. That's where we normally just adjourn to closed session. And in closed session today, we have Kathy Rock here with us, who's brand new to PhD and worked in HSD with Centennial Care. So we want to continue just talking about Centennial Care today. And Mike Mulligan's here as well. So I'll make sure that we continue the conversation we had at the last meeting, where we had a lot of questions, didn't have a lot of answers. We had a lot of questions about it, and maybe we'll have more answers this time. And then later we'll also talk about the capital meeting. I'll bring that up later that we had yesterday, about capital for facilities and our projects. So that was a very good meeting. Michael Brown did a superb job with that yesterday. And Linda Kehoe was very helpful. So that went very well. And we may be having we'll have a follow-up discussion, I think, with LFC and DFA and maybe HSD, do a follow-up meeting with a much smaller number of us to continue the conversation we had last time about Medicaid expansion and opportunities for general fund reduction. So we'll talk about those later today. So I would like a motion to approve the agenda. Make a motion, ask for a motion to approve the agenda.
Just a motion.
Okay, second?
Second.
All in favor?
Aye.
Thank you. And then the approval of the minutes of the previous meetings. There's two. We did have to have on August 16th, and actually, is that the only one, Kathy, or did we have we had a second one, didn't we, or was it just August 16th?
No, just August 16th.
Okay, so July 11th was our minutes from our prior quarterly meeting. August 16th was an emergency governing board meeting for credentialing only, right?
Correct.
We had some credentialing to do. So we could take a moment to look at those. We also have, as we do each time, the administrative reports from the last meetings, July, which could be too much comment on. Basically up through page 22. And can I have a motion to approve both the minutes from July 11th, 2013, and also August 16th,
So moved.
2013? Second?
Second.
All in favor?
Aye.
Opposed? Motion passes unanimously. Thank you. And going into new business reports, today I'm going to ask Retta if she has any comments she'd like to make first.
First of all, I want to thank Troy for hosting us today, for the graciousness of you and your staff. It's a beautiful facility. I know you're really proud of all the work that CYFD does. So thank you for hosting us today. And I want to thank everybody for your hard work that led to a very successful LFC preliminary hearing that we had. I know a lot of time and effort went into making that successful, and I really appreciate your efforts. I also appreciate the work that went into the meeting that we had with the LFC regarding changes in our possible reimbursement because of Medicaid expansion and the Affordable Care Act. We want to make sure we get that right. We want to make sure that LFC knows exactly what we believe the impact will be. And I was really grateful that we were able to have representatives from Human Services, and Kathy Rock came from Human Services, so she is a Medicaid expert as well. I'm really grateful to have her on our staff to advise us as we go forward as well. So thank you very much for that. As Brad mentioned, we have another meeting that the LFC has requested with us. It'll be a small group of folks, but we may be contacting you for additional information because they do want to make sure that we are capturing all the possible revenue that we can. And obviously we're interested in doing that as well. And we want to make sure that they understand that we have researched and we have investigated and that we are confident that we are going to be capturing all of the Medicaid reimbursement dollars that we can because of the expansion. We also are gearing up for the FY14 legislative session, and one of the governor's initiatives is around expanding the healthcare workforce in New Mexico, and there are a number of initiatives that are going to be put forward. One of them involves certification of community health workers. There are some other initiatives surrounding reciprocity for nurse practitioners, expanding our capacity to train nurses in New Mexico. And once we have all the details on those, we'll talk about those at one of our upcoming meetings. But there is a big recognition that we have a crisis in New Mexico, and that the gap between what we have and what we'll be able to hire may grow unless we take some steps forward. We also are looking at an alternative pay line for nurses, social workers, other healthcare workers. That's been worked on at SPO for a long time, and I think it's just about ready to be presented to the governor's office. That would have to be included in appropriation language, but that is urgent, and I think there is a recognition that there is an urgent need for these alternative pay lines. and it will become even more urgent as the Affordable Care Act rolls out and Medicaid expansion rolls out. So thank you all for your work and for your assistance as we move forward into this next legislative session and our formal LFC hearing in December, which will be a modified version of the preliminary hearing. But we got very good feedback from Representative Varela, who's on that committee, and from some other people on that committee. So your hard work and diligence in helping us prep for that has paid off. I'm very grateful. Thank you.
And I'll save most of my comments for later. I'll make sure that I do have the PowerPoint from yesterday's, from Michael's presentation for capital. So I'll go over that with everybody and just kind of summarize a little bit later how that meeting went, which I thought went well. As well as Linda Kehoe has been a very strong advocate for us. And probably, as Retta said, next we're working with Ruby Ann and with DFA to see whether next Thursday or Friday, with everybody's busy schedules they have, that we can, a small group of us can meet and continue the discussion with them about the opportunities, if there are opportunities for general fund cuts. So we'll continue that discussion. So as Retta said, we may have to ask you a few questions, but you won't have to go. All the administrators are not required to go to that. It'll be a smaller meeting, and we'll probably be more our budget team, and we may have somebody there from HSD. So we'll just let people know about that. But continuation of our other conversation. We do have a. I guess I can now announce we have a new chief medical officer who's accepted our offer to him, and he's going to start approximately the beginning of December in his position. And his name is Dr. Stephen Dorman. So if you have, I think Troy, you've met him, and some of you have already met him, but he's a national expert in a lot of areas: Joint Commission and performance improvement and peer review, credentialing, all those areas. He's a national expert. So we're really lucky to get somebody of that caliber to join us. I know Louis will be working very closely with him. So I think in our credentialing process, that'll help that as well. And some of our facilities are working on getting Joint Commission accreditation, such as Turquoise Lodge and Fort Bayard. I think we're putting some emphasis first in the Turquoise. So Louis kind of going to be more on the ground there, and Gail, eventually Dr. Dorman. So I think we're going to put a lot of emphasis on trying to get Turquoise Lodge momentum going to get Joint Commission accredited there, and also then do the same thing at Fort Bayard. So we have been, we've always been looking for a chief facilities officer other than me, doing that. We're hopeful. We're still talking to a candidate there, and we're still hopeful that we'll be able to get an acceptance there too. If not, then we'll continue looking. But we're hoping we have somebody for that position soon also. I think that's primarily the main things I just wanted to mention for a moment. And I guess, Troy, you're the host today, so we'll start with you with the administrative reports.
We start with me every
So,
That's okay.
So good at this.
My report's on page 23, everyone. You can follow along. I'll try to go over it painlessly. In regards to our statistics, our census, our adult psych division, we had 215 admissions, 224 discharges. Our average daily census has been about 73, which has come down, and it's a welcome relief. We were running up into the high 90s, and the ebb and flow that we normally see wasn't happening. It was constantly high acuity and number of admissions. So over the last quarter, we've seen just a little bit of a drop in that, which is a welcome relief for our staff. This is one place we don't advertise for patients to come in because we usually have plenty. Our adolescent unit had 3 admissions, 2 discharges, and they were running an average census of 10. Our forensics division had 47 admissions, 55 discharges, and we're running an average census of 59. They're still maintaining right at 37 of our 1.5s that we talk about. In our long-term care, which is where we're sitting today, part of it, we had 6 admissions, 6 discharges, 5 of those were deaths, and an average daily census of 151. Our construction, phase 2, some of you got the opportunity to go through that construction piece this morning. You can see that it's coming along hopefully will be done by February. They were ahead of schedule. The rain that we received here and some of the weather kind of slowed them down, but they're really not projected to be done until March, so they're still ahead of schedule and looking at February. The building right across from us is our Old Meadows. As soon as we have phase 2 done, we received $2.1 million to demolish that building, and so that's in the works, ready to go as soon as our last resident crosses that threshold. The bulldozers are supposedly going in and knocking it down.
Glad you put that sentence in too.
We'll do it without the staff or residents in there. Trying to be nice about that. Part of the tour this afternoon, you will get to see our forensic salary court. It's really increased our security. Contraband has gone down coming into the building. Everyone, new admissions, all the staff have to come in through the Sally Port, checked before they get to go into the main population. Our visitation rooms are even now between glass, so the family members can't pass things to their loved ones when they're there visiting. So we've really seen a nice increase in that. Under the personnel section, we had 41 staff that we hired this quarter. 12 of those were new employees, a lot of movement internally. And we did lose 43 with this new changes in the para. A lot of individuals that are eligible to retire. We're having a lot of retirements, which is good for them, but a lot of history and knowledge for the facility is going to be lost, so it's always a scary thing. Our orientation, which is going on actually as we speak in the building across, we have 34 new hires in there. We didn't have space in our staff development room to do the orientation, so it's a large group and we're hoping that they continue like that. We unfortunately lost Dr. We call her Dr. K, Dr. Krasowski. She was our chief of psychiatry. She had worked in New Zealand before and had a dream of going back, and her dream job came up and they offered her the job. So she's now in New Zealand, and her leadership is really going to be missed. She did a lot of great things here. We also lost one of our part-time FTE psychiatrists from our adolescent unit. We were fortunate shortly after that to have a board-certified child psychiatrist wanted to come on as a contractor, so we hired him and placed him over there. He started last week, giving us 2 days a week, and he's doing an excellent job. I won't go through all these surveys, just to hit a couple of them here. The long-term care division, we actually had a complaint survey there, adult psych division. Both of those were found with 0 deficiencies noted, and actually praise given to our staff on how well the investigations were done. And these were, when we say they come in as a complaint survey, we're the ones that do the reporting. So they're coming in because we made the complaint. We said there was an allegation of, and we said send it in. So they come out and then they looked at our processes and actually praised us on that. The fire marshal usually would take 3 to 4 months to do their inspection with one fire marshal. They actually came in with a whole busload of them, and they got it done in a week. We did really well waiting on the report. They were very complimentary of all of our staff. Under just miscellaneous items, we put together we talked about this before, going smoke-free or tobacco-free. We did put together a performance improvement committee and team on that. Actually, everyone's pretty excited about making that happen. Still making some decisions on, is it going to be all at once with the staff and the patients, or are we going to start with the patients, work our way through the staff? The Western Psychiatric State Hospital Association meeting that I attended, we are the only state psychiatric hospital in the Western Hemisphere that has not gone smoke-free or tobacco-free at our campus. So we are moving in that direction. We've moved in that direction before, but then have had changes to that. So we're really excited about moving forward, getting that. We're the Department of Health, try to be healthy. It's going to really kill our cigarette sales, and we were trying to wait until after. This is a joke, but we were trying to wait until after the session so we could get as much cigarette tax money as we could to help out with phase 3 of our metals project. That's a joke. Actually, at the Western State Psychiatric Hospital, I was asked to stay, that association meeting, I was asked to stay after and be part of a committee for nationally looking at the role of state psychiatric hospitals in the future. And a lot of them are moving toward sexually violent predators for civil commitments, which is already in a lot of states. And they're looking at their forensic population significantly increasing. One of the things that a very small subset of state psychiatric hospitals wanted to look at was becoming the premier place that you would want to take your loved one if they needed our type of services to come in and receive it here, like the MD Anderson for cancer. State hospitals should be the specialists in dealing with some of the more difficult cases. So there was a wide variety of where they're moving. that's getting put into, and that actual paper goes to the Capitol to be looked at and reviewed. So when I get copies of that and they're given for drafts, I'll make sure that you guys get to see it and go through it. The last bullet there is we did do our PI management report. It's completed, and I know part of my requirement for the Joint Commission is to have that reviewed and approved by members of the governing body. I'm not sure if we want to pass that out now and have that chance for people to look at it and come back to it and maybe approve. So we just pass some of those around.
Sure.
As part of closing out FY13, we actually also look at FY14 where we're heading. So we came up with a plan. Our focus is really going to be on a high reliability institution and organization. We want to focus on, we're really good at catching things. We have an event, and then we look at it, analyze it, find out what caused that. We want to get to the point where we're preventing that way before, finding the small things, and the terminology that's kind of fresh and in our minds is high reliability. But we're also going to be looking at excellence of care, which goes back to what I was talking about. I want every one of my staff members here, if their loved one needed our service, this is where you would want to bring your loved one and family member to get that care. Not looked at as the, I know we're a safety net, but I don't want to be looked at in the negative connotation of a safety net where this is the last place you end up. I want people to bring in their loved ones and family members here to get the best care that they can. And so we're having a quality retreat, and we would really love for you to be there, Secretary Ward and Brad, and I know we are going to invite Gail. I know schedules are hard, but we wanted to pull that together. We've identified some of our indicators, our performance indicators, and our quality measures for next year, for the year we're in now, but wanted to finalize that and get some input from leadership.
When were you thinking about doing it?
We were. The initial goal was to have it after this meeting, but I knew it wasn't going to work because of the tours that you were here. I had a captive audience. So we were going to be asking you guys for anytime at the end of this month from here on, or anytime in November that you would have on your schedules would be great to let us know, and we'll work our schedules around that.
I wish, unfortunately, Dr. Dorman won't get here till beginning of December, but I know Gail, of course, would be extremely interested in that as well, as we would too.
Great.
So you're thinking,
can I contact Kevin and ask him to look and see what's available for everyone and get back to us? And,
sure.
Because we'll make it work.
All right, sounds good.
Dr. Dorman has already asked when the medical staff meets here, so I think he's planning on being here in December for their medical staff meetings.
Yeah, I think he is.
I just have a quick question for you. Do you see part of the role of a state hospital also including like implementation of evidence-based practices, or looking at being able to do things because you have a little bit more time, or you have dedicated staff that don't have to bill around even like medication practices or new practices or things that you could do experimentally here and then we could learn from the community?
I know the discussion that took place with the national group, there was their evidence-based practices that's going to be a strong component throughout the document that's sent up to Washington. I think that we have the ability to do that. We used to do research here years ago on the new medications that were coming out. They would actually come here and we would go through the process of getting it approved, the IRVs and everything else to have that research done. Clozaril was a big one that was done here. Olanzapine was one of the big ones that we did studies here on the new medication. So absolutely. We're also tying in with another big factor that we've been working on, and I think it was close to fruition with Dr. K, is affiliating with universities. And we have piecemeals of that, where all the nursing programs from throughout the state come here for their practicums and internship sites. We now have two residents that are coming in January and February because they're interested in our forensic program, our adolescent sex offender program. We want to formalize that to make this a regular rotation for them and have it as to where it's a training place also for residents, because what you see here you won't see in other places throughout the state. We have some of the more difficult cases, so it's a great training and learning opportunity.
I've seen that work really well. And we actually brought up dialectic behavior therapy in Missouri because of the work they did at Fulton State Hospital, and really being able to use some of the PhD students in that, and then they helped us through consultation teams in the community then be able to learn off of what they learned at the state hospital.
Yeah,
I think that would be a great opportunity to do more of that.
Heading in that direction.
And Troy, maybe I misheard, or I think Teresa mentioned that she thought you might have a lead on a psychiatrist, or
I have a chief of psychiatry candidate that is very interested. We're trying to get the position posted so he can apply. I have him developing his application and everything, working him through that. Docs aren't the best at computers, if you've ever noticed that. So we're babysitting that process along. Where he works, he has to give a 4-month notice. So as soon as I could get that offer on the table and made, he could then give his 4-month notice.
So I know she's working on that. That's the impression I got last night. We went over some stuff, and that's good. That's hard. You know, it's not easy to.
Well, that position had been vacant for more than 2 years. We had no one we posted it multiple times, but it had never been filled, so we had to go through DFA to ask for requests to get it.
Michael Marcelli to
yes, exactly.
that.
Yes, sir.
That's correct. So that's good. We'll make sure that we help you with that. Okay, thank you. And so I guess Daphne and Tomas, I'm not sure if you came in after Troy mentioned that after this meeting, if you're interested in touring, there's going to be more opportunities to tour. I know, as well as we're having an expansion to this facility, which is gorgeous. But this is a really diverse campus. Troy talks about forensics. I think. Well, why don't you just tell everybody again when we say forensics, with that type of lockup type facility.
It's a highly secure area. It's the building that you see when you're driving down the road with all the concertina wire around it. These individuals all have a felony charge. Competency has been raised as a question in one way, shape, or form. They'll come to our facility either for treat to competency or assess for competency. We even have some individuals that are found not competent, not restorable, yet dangerous. The courts can place them here for what would have been the duration of their term had they been found guilty, had they gone through the court process. That's the population we refer to as our 1.5s. And those individuals, we have people here from 3-year stints to multiple life term stays. So aging population that we see needing a lot of medical care and treatment, and if the courts allow, there are some that do transfer out to then like a nursing home setting because they're no longer considered dangerous. But that depends on the court.
Right. Very diverse because we have the psych area, we have the psych unit, also the adult psych unit, we also have the care or the adolescent sex offender.
We also have out on Freedman Avenue downtown, there's one of the largest community mental health centers. They're the core service agency for all of San Miguel County. And we have outline clinics in Santa Rosa, Mora, and Pecos.
It took me several days really when I first started to actually tour here,
300 acres, 47, 48 now with the building going up over there, 48 buildings.
Right, it's a big campus. I know you won't cover all that today, but
we're going to cover 300 acres, absolutely.
Is that why we needed boots?
Tennis shoes.
And 3 graveyards.
We have three graveyards, absolutely.
That's right. We do. We're finding more every week, I think. We are.
Yeah. I have a couple questions.
Yes, go ahead.
Your administrator mentioned something about the restraint-free
nursing home.
Yeah.
We've got a couple of initiatives that have gone on. We've been working toward a restraint-free nursing home for quite some time. We've actually been able to get to that point and maintain it, so now we're actually applying for the, what is it called, Lori, the restraint-free?
The designation.
Designation, that's the right term. We're also looking at, the performance improvement team has already gone underway looking at reducing psychotropic medications in individuals with dementia is that one of the areas that's recommended, but we're also looking at just reducing psychotropic medications in all of our population that are in our nursing home. And it's taken off pretty gallantly. We had a really good meeting yesterday that a lot of staff were invested in pharmacy, the docs, so really, really exciting.
And then I have sort of a question. It goes back from my background in working with Solid Valley Mental Health. And with the chronically mentally ill folk that we were dealing with, the smoking, you're saying you want to go smoke free. These guys were constantly smoking. How are you going to deal with that component? I mean, is it just designated areas that you would have for them, or you're just going to?
It would be campus-wide smoke-free, absolutely. That's already initiated in our forensics division, where all of the patients that come into forensics are smoke-free. They're not allowed to smoke. Years ago, they would come in from a detention center, not smoking, come into our forensics department with selling cigarettes. I was like, this isn't making sense, so we put a stop to that. some of the older research would show that individuals with schizophrenia and some of the psychotic disorders would smoke because the nicotine would actually reduce their auditory hallucinations. That's actually not proven out, and I think a lot of it is just habitual stuff that they get into, and then they get addicted to the nicotine. What they've seen in the Western Psychiatric State Hospital Association and nationally, patients are the easiest ones to have come off of the cigarettes. The problems are going to be the staff, where most of the difficulties occur, because it's really in a controlled environment. It's easy to deal with. I mean, our local hospital is smoke-free. Most hospitals are smoke-free now. Like I said, we're the only state psychiatric hospital in the Western Hemisphere that still allows people to smoke, or patients to smoke.
Lori's done a fantastic job at her facility in Tier C with making it a smoke-free environment.
We're going to follow that model.
And the employees now hike 2 miles to the smoke.
They get their exercise.
That's why I learned to smoke was in the military. Everybody was taking breaks to smoke, and the rest of us had to stand at attention. It didn't take me long to pick up a smoker.
I never really smoked, but I stood there and held it so I could go on break too.
All right, well, thank you,
All right,
Troy.
thank you, sir.
And
Thank you for it. Thank you.
Louis, I may ask you to help, because I know Charles is not here today for Sequoia, and I'll add some comments too, because I know we just had another review with CYFD, but on page 25, would you feel comfortable
Sure.
talking through some of that? And we'll also talk about the, I know that, I think that went well too, so
Okay.
go ahead and make some comments on that.
All righty. Well, their census for October is 13, of the little beds at 36. There's word about them increasing the census little by little, and they have started to restructure their admission process to make it more efficient to get clients in there sooner. It's a little cumbersome right now. It's really hard the admission process.
You may have to speak, I'll give you a microphone there. We may have somebody to be on the line.
Okay. All right. So some of their projects, the security cameras, they've had people down from Santa Fe, the capital people, looking around and seeing how they're going to fund that. And of course the fob system, the HVAC system, the courtyard project. If you've ever been to Sequoia, their courtyard is really sort of bland for that age of client. You would expect to see more green grass, places to play, and so it's going to take some organizing, and I think they have a good team working on it. Right now they went through their licensing survey last week, and this was sort of a follow-up licensing visit from some findings that they had earlier in March, and where they sort of they put the organization on provisional licensing, and we had to prove ourselves within 6 months, and so they came back to sort of a validation survey and looked at everything that the team has been doing, and they found that there have been lots of progress. The seclusion and restraints, there hasn't been a restraint there in months. There was one that was used briefly, like for less than a minute, to hold someone that was acting out. The seclusions are dropping way down. They closed what used to be their sort of intensive seclusion room area, and made it into this beautiful, soothing office sort of space where if they're feeling like they need to get out of the population, a therapist can take them into this room. Beautiful, soothing furniture, paintings, music. All I commented was that they needed aromatherapy. They needed some lavender in there, but other than that, that building just totally transformed. If you can imagine what that unit looked like with these huge doors, jail doors that locked with these swinging things that locked, and the beds where the straps, they used to strap the people down, and it's a terrible, ugly, ugly environment. And walking into that place today, you wouldn't even know that had a formal existence. It's just,
Great.
yeah, a form of existence. It's beautiful. They started to use sensory carts where they have on the units weighted blankets for comfort. So if somebody's feeling like they need a little bit more comfort, the client will go and ask the staff, can I borrow that blanket? And it's really, really soothing to have it on you. They have other sensory supplies that they're using sort of to divert their attention from their behavior. The staff has already been trained in CPI, a different form of crisis intervention and prevention. They've, what else is going on down there?
Well, yeah, anyway, your second page, building bridges is
Building
continuing.
bridges.
Building bridges.
In fact, that's where Gail is today. The Building Bridges Initiative, they've already started to implement quite a few of the concepts of building bridges. Trauma-informed care, moving away from points and levels. That's one thing that they really want to do because they find that that's what gets the clients riled up when you drop them a level or a point. So they're trying to work with the staff to train them to avoid dropping levels or using levels or points, period. Policies and procedures are being updated and reviewed. Internal review process has really improved now that they have people doing the investigations, and Carmela has sort of trained them all on policy and procedure on the internal review process. Let's see. They're moving right along. Secretary Ward asked me this morning when we'll find out from CYFD, and they're hoping they're supposed to get word to us within 10 to 15 days after their survey, so we're hoping for full licensure. They're continuing to monitor the program. They will continue, Shauna Hartley will work with Sequoia to monitor some of the processes.
Right. She's been great. Sean Hartley's been a huge help to us.
Shauna has been remarkable for working for CYFD, coming in and working with the staff. And she has a lot of knowledge because she's run facilities before. And so her knowledge of treatment planning, and, oh man, she's just been really, really good.
Good, great.
With. Yeah.
I like your new tradition there. I know.
Me too.
I like to see pictures of that or something.
Yeah, it's really beautiful. It's a really neat ceremony. It's a way to send them off back into the community or where they're going. So it's really a nice. And Charles is just rolling up his sleeves and running through the coals. He's been baptized by fire, and he's really rolling up his sleeves and getting to work. So.
I know our goal was deliberately to drop the number down to 12 or 13. Now we're gradually working it back up. We did that just I think in terms of working with CYFD, we wanted to focus on making it the best environment, safest environment. And it was easier to do that with a smaller population, I think.
Sure.
Now gradually the population will go back up again.
Absolutely. And then also I'd like to recognize Carmela Sandoval, who's done a tremendous amount of work down there, trying to get them
Right.
good status. She spent a whole lot of time down there working with the staff and developing new procedures and policies and so forth. So she needs to be recognized. And she's done a wonderful job.
Daphne, do you have some comments?
I'm just really pleased. I didn't know. The good thing is I didn't get any emails about the survey last week.
Oh, okay.
So that's good. That means it's running on in a routine way. I'm just really excited. And we set off to make this work out, and it sounds like it's working really well.
It is.
This is the only level of care. Sequoia really is sort of like the state hospital for adolescent males in some ways, and we recognize the complications there. I'm just really pleased and hope that the partnership with YWC and some of the CYFD facilities there in Albuquerque will continue as well.
Absolutely.
I think that was very fruitful.
And I think that's one of the initiatives is that they had their second meeting yesterday with the initiative, with all the different agencies that came together to see how they could support one another. But Daphne, you're always welcome to visit anytime. Let us know and come to the facility and see all the good work. And you're always welcome.
I think we should have at least one more meeting just to celebrate the good work.
That's a good idea.
That would be nice, because the last one we were beginning the process,
Right.
and we may be celebrating it this time. That's awesome.
Yeah, That would be more balloons.
Yeah, we can put affirmations and balloons and stuff on. That's great.
That's a great idea. We'll keep that in mind, definitely.
Well, thank you,
Great,
Louis.
very good news.
Thanks.
I mentioned earlier, Mike, we go to Turquoise Lodge Hospital, and I had mentioned earlier that that's one of our next focuses now, is working with you and your team to help you get prepared for Joint Commission. It's a long process, but both Gail is and has been a Joint Commission surveyor, and Dr. Dorman has been for at least a dozen years, I think, a Joint Commission surveyor. So that should certainly be helpful.
Well, it's exciting. Gail's already given us some good ideas. We've already sort of jumped in front of that. We do have the surveyors coming into the facility December 5th and 6th, pre-surveyors, I should say. I can't say how much Louis has been helpful for us in reference to getting us organized, putting some plans together. For the last 2 weeks, we've been juggling a couple different programs with LLC and the facility itself. But Louis has been right in the middle of that, trying to make sure that we have a plan in place so that people know exactly what we need to do. How we get to December 5th without having a blank sheet of paper in front of us.
Right.
So I just wanted to thank Louis for that. We've been busy at Turquoise. I think I haven't had a chance to sit back and read the paper since I got there. We started off with the adolescent program, and it's been very busy at Turquoise. We got that up and running. We've had 25 kids that have gone to the program in this last quarter. There's some demographic data that I supplied in our report today, and I won't necessarily go through each one because there's different demographic breakouts for the females and what they use, those kind of things. Our success rate, I think, is right over 50% for the adolescents. We're still working on that program. Again, I think, as we mentioned with Sequoia, with building bridges, that's something that we've really sort of tagged on with Sequoia. In fact, our clinical director is in that training today, and we're looking at how we're going to implement that at Turquoise, because I think it's working out great there. The staff is excited about implementing that.
Right.
Evidence-based practices as well as trauma-informed care. Those are the new, that's the new lingo out there, and that's really what Building Bridges is all about. CPI, we're right in step with Sequoia as well. We've been doing that for a long time. In fact, we've shared our trainer with Sequoia so that we can make sure that their staff is taken care of.
Right.
And they're
We're doing a lot of things, so the two facilities are working closely together now.
yeah, and I'm glad you bring that up, Brad, because one of the things is that even though they're an RTC, I kind of envision us as a step down from that. And although Sequoia only handles adolescent boys, we handle females and males, which is a little more challenging, but we're getting the hang of that, I think. There's some challenges that go along with that. We don't want to forget about our adult program. That's the census on our adult is running at 96% full at any given time. We had 160 people come in for the first quarter that seek treatment at Turquoise. In the adolescent program, we're running about 10 to 11 beds right now. The capacity on the adolescent is 34. We're going to get there. We're trying to hire about 5 new tech positions to be able to help subsidize that. And we just got a list yesterday when I walked out the door, so we're setting up interviews. We're confident that by December we'll be able to move that number up to about 14 or 50 and see how it rolls out from there.
You mentioned Optum on here too, the first one.
Yeah.
Continue to work on that, which is good.
With Optum, yeah, we're still working on that contract, and I know Mike Mulligan and Leonard have both been very helpful on that piece. We're trying to push that through. We do have a contract for the first 6 months of the year with Optum to pay for our adolescent patients, both detox and rehab. It's been a little challenging because the rehab portion of their stay, there's not a code built into the system. So we've had to sort of be very creative. They're creating a code for us so that they can reimburse us on that route. It's coming through the value-added service, unfortunately, so it's that extra pot of money. But they're very committed to getting that up and running. They're going to allow us to back bill all the way to July. So based on the patients that we serve from July to December, we'll be able to bill and hopefully bring in some revenue.
We'll talk more about Centennial Care later today.
Yeah.
We'll talk about January 1 going forward next year, but that's great for now.
And we're trying to push that onto Centennial Care so it kind of bleeds into that so that maybe it sort of gets legs. I'm hoping that Ms. Rock and Mike and Leonard can hopefully arm wrestle some funding for us on that end or come up with some creative ideas for us to maybe leverage that. It could possibly be an infusion from anywhere from $2 million to almost $3 million if as possible. So in my stay here, I think any little money that you can bring in is beneficial to the program. One significant thing is we've been really focusing with the county on our food. It's a third-party contract through the jail contract that they have. The county has actually stepped up in reference to trying to provide better food for the program. Again, the mentality from MDC is that they're in a lockdown facility, and unfortunately, we're in a hospital setting, so we're trying to sort of peel off that piece so we get more of a hospital quality grade food without having to negotiate too much on the price side. We've been focusing on presentation, palatability, and adding fresh vegetables. I think those three things in itself make people want to eat something on the plate.
Right.
The county, Katrina's been pushing that. They've actually been in negotiation. I think they've gotten fined at times because they haven't followed their menus. So they're really sort of tightening the screws on that piece. We just had this just happened yesterday, but we spent the day with the backup generator for the facility. They were going to test that through the county, and we had a really successful sort of backup generator process where we went to the entire facility to make sure that it worked, that it stayed on, what worked, what didn't. So we have we're still sort of putting that data together, and we found a couple areas that were missing or that we can improve on. So it was very valuable for us, especially now before Joint Commission steps in the door. So we'll have something to add for Louis' meeting tomorrow because we're going to follow up with that Joint Commission piece. The only other highlights I'd like to mention, again, I've put a lot of demographic data for your viewing there, but I will mention that we put a lot of work into the improvement on our adult clinical program and our adolescent program. And we've added training, changed some policies that are going to have to come up for review. We've changed the programming, and some of the focuses there are making sure that it's trauma-informed care. We're splitting the genders, making sure that we're more vigilant on their on the med passes as well as when they're walking through the facility. We've added cameras to the unit as well. That's a big piece for us, which really helps. And then for the adolescents, again, focus is on building bridges, which I think is going to be great as we move forward with the adolescent program.
Let me ask you a question, Mike. I should have asked the other administrators this too. On the flu vaccinations, I guess going back to Troy, and I'm not sure with Louis about Sequoia, but what are we doing or not doing in terms of, I guess, vaccinating or providing opportunities for employees and staff and patients to get vaccinated?
We're rolling out the red carpet. We actually have stations. I got mine. It was last week. They go around to different areas. We can have them come. I forget the name of the company that's actually coming in. It's free to the staff. Patients, we're always high on our patients. We get all the nursing home done, and as many as we can that are willing to get it done, or the guardian to have it done. On the psych side of forensics, it's more the staff that we've always struggled with, trying to get them to take that. We've made a lot of improvement over the last couple of years, and we're still pushing to try to increase that. But we're making every opportunity available to the staff, even going to the units to the staff, and outside the unit, having one staff come out, get the shot, go back in, and move them out.
Mike, you're saying you're doing that here. You've got that.
Yes, sir. And if I may, I would like to add that we've since we sent this information up to you last week, we've completed all our staff have either been vaccinated or have declined to be vaccinated. Unfortunately, we jumped in front of this before the new form was sent out by Mike Landon. So we're going to have to go back and have we have to address the new form that's out there.
I think track better this year.
I think it'll be helpful because that new form that Mike has breaks out why people don't want the shot. It actually makes them give a reason besides I don't want it. So I think maybe that's helpful for us just demographically.
We just want to show that we have some way of proving that we did a good job.
And
I think we're all tracking that at our facilities, and at the declination page, we have to have them fill out if they don't have it. And we even set up, I think it was ice cream and cake for the unit that had the most individuals, as a party for their unit. So there's a couple of departments that are really pushing that, and we want that cake and ice cream.
I'm not sure if you know about Sequoia at all.
I know David was working on it, so I don't know too much.
Right.
But it's also a Joint Commission standard that we have to track the reason why they're not taking it.
So we are going to start doing that. The patients is the other thing that we do. We do all our patients. We're about 95%. We have to have a better tracking mechanism for that because we're treating not only our patients, our 700 patients that go through Turquoise, but also the 3,500 that come from O2. So we're hitting a lot of people with flu vaccinations, which I think is beneficial. I'm hoping that we're maybe making a dent for public health.
Okay,
Those
great.
folks, we see them one day and then they're gone.
On the flu strain, what's the word on that? Is it problematic as it has been, or is it still too premature to really get a sense?
We don't have many cases of the flu yet, have we?
The CDC's been shut down, so.
If I had work today, we can call it tomorrow.
Yeah, tomorrow we'll know.
I think the big fear that we saw, our medical provider mentioned, was that we had probably one of the earliest cases that was tracked in so many years. So I think they were worried that the flu's starting very early, and we usually wait for the flu shot to be given late in November, somewhere in November. So we started giving it early because of that.
We want to be assertive.
But the good news is that that strain that was identified in September is one that's in the flu vaccine,
I didn't
so
know.
that is good news.
And then with pneumonia, do you guys do the pneumonia vaccines?
For the residents.
I just have a quick question for Mike. Mike, I was looking at the discharge, and only one was discharged to a core service agency.
Yes.
Are you guys having difficulty interfacing with
Yeah.
CSAs? And I want to make sure, because all of those youth with chronic substance abuse are considered core service agency members. I don't want to miss out on their opportunity to get what benefits go with that. So I can, if you want to talk offline, I want to be sure and help you with that, because that's something that's very important, that we recognize that those adolescents get in there and become core service agency members. Really pleased to see the 29% IOP, because that's the step down that we were envisioning, but I'm kind of concerned that your CSA interface is low, and I'm guessing that's not because you're not trying.
No, I think there's a couple things that go along with that. One is that they closed the flu down, and there's some strain on that end. And I think we're sort of trying to develop statewide, so with that comes some other challenges along with not just focusing on Bernalillo County.
Well, I wanna
Bernalillo
make
County, I think,
sure-
only had one or two. What I'd like to do is we're strategizing internally. We have a meeting next week with the clinical staff and adolescent and our nursing staff. I'd like to maybe see if I can volunteer you to have some time, and maybe we can do a conference call.
Sure.
Because we're strategizing on how we can improve that, so we can get more people in the room.
Can I also add that that's going to be part of the quality plan? It's going to be built in, where they will have a whole section on discharge planning, so that when the client comes in, whoever does discharge planning starts it immediately. And
Well, and that's exactly what we wanted to do.
creates a running list of what services that client is going to need when they discharge. And it's sort of going to read like a story. So as you follow their treatment, you're going to see that, they connected with this service, this isn't available, we're going to do this. So that's going to be part of the quality plan, the appropriateness of the discharge, and it's also, we're looking at ways to follow up on 12 months post-discharge.
Great.
So,
Well, I will also, Mike raised this as an issue. We have a weekly meeting with HSD and Optum around transition issues.
Yes, ma'am.
And we want to make sure, I want to make sure that this part of our population gets a seamless transition like we're supposed to. So I will make a point to raise this as an issue on our Friday call and then follow up with you. But it would be really helpful if we could know, of the 4 CSAs, where you referred, where they were turned down, and that sort of thing, so we can really nail it down specifically
We have that.
about
Put
access.
it in this.
That's very
But I
important.
think that's the kind of access information. We need to make sure that we are getting what we deserve from that.
Back at the beginning of this, when this was a concept with the adolescent program, the governor's office, I know emphasized that too, that they want to make sure that, we're not responsible for phase 2, phase 3, so to speak, directly, but we have to have that handoff system strengthened. So,
And it has to work, and those youth would be entitled to ready access to the system. So if that's not happening, I really need to know that so I can follow up and make sure that that happens, because it's very important to us that our youth get access to those
Great.
step-down services, and they deserve them. And we have agencies saying that they do that. So we just want to make sure we give them the full opportunity to put their money where their mouth is.
Right.
That was a comment I was actually going to make. We saw some of that when there was some concerns around the 15 providers and the transitions that were taking place. We would make contact for our adults and adult psych calling out and they'd say, oh, we're not taking any new people or we're no longer open. So having that connection with Optum is the real important one because we have I call it the hotline. If we get that message from any of the providers, we contact Optum. Next thing you know, that provider's calling us back, send Troy over, we have a spot for him. So
absolutely. And Tim
Optum
Miller is
connection.
really the primary person at Optum that might probably even want to call him directly if you're not getting ready access to an assessment appointment and then follow up. It's very serious, and we want to make sure that reality is following along. And I know it's important to everyone.
Good, great. That's good dialogue.
Yes, thank you. Mike.
Absolutely.
Anything that we can improve that program, we're all for.
Well, just one last question too. With the adolescents, I was thinking when I see Tomas sitting there with education on the adolescent side, can you comment on that? I mean, how do we try to address during their stay there?
So
education?
I'm not sure I'm glad you brought that up, but I'm glad you brought that up. Part of it
Might
is
be an opportunity for improvement.
yeah. Well, we again when we roll this out and we're getting needs from across the state, it's a little harder for us to put a plan in place because every school wants to operate in their own silo. So I think on one of our pages there, we had an adolescent program. We dealt with different counties, and what I didn't include it, I'm sorry, is we do have the actual schools that they were going to.
Right.
And I have that breakout, and what I'll do is I'll include that next time in our demographics, but we do break it out by what school they're going to. A lot of them are chartered. One of the things that we do internally is we've set up a program, and I just lost the name, but we do a GED program locally with the old Ogatis building area. And so we take any kid that has not graduated or feels like they need a GED program, we take them and we get that service done 2 times a week. So it's an exciting piece for them to be able to continue their education. There's a couple older kids that don't want to go back to school, so we're trying to link them up. We've been working with CNM to try to do some sort of job training program because again, they're not going back to school. What do we do with those folks?
Right.
And then with the smaller communities, it's hit and miss because they go into, for instance, they come back to Las Vegas. What school are they going to? So we have to do that or whatever.
All right.
But I do have that data, and I'll send you an email on that, Tomas.
Thank you.
I was gonna ask that question there too, Brad. The educational support that is being provided to those students.
Now, I think it's we've met with different organizations or different districts, and some are more willing to work with us than others. And I think it really revolves around funding. And the way the new setup is that some schools don't want to take these kids, and then it'll hurt their numbers and it'll hurt their scoring, and then they don't get the money for it. And at the end of the day, it's the money. So we've been trying to be proactive on ways around that.
We'll keep talking about that one.
And I think another issue is the length of time that they're staying
like
there.
30 days or less, right?
It's a 30-day program, and I think our census is running about 22 days, right? Our length of stay is about 20 days for our adolescents. And the reason for that is because we have the people that are finishing the program are sure they're there for 30 days. We may have a few that come in, don't like the program, and they leave. They want to leave, and then that cuts into our average. So it's unfortunate, but that program's not for everybody, and we want to make sure that we're.
It sounds like Sequoia were there for a much longer period of time.
Yes.
And I think that sometimes when you have a policy conflict like that between with the schools, and
yes,
they're saying, well, the existing policy creates a situation for us where we really can't afford to or don't want to. I think what I'm finding from PED is that they're willing to take a look at some of those things.
What they've told us is we should probably add an FT and add a teacher. And so the focus is like we don't have enough staff. We're short staffed.
Well,
we really need that support.
Maybe we should.
And we're looking at that. Again, I haven't got there yet because of the support that we're getting.
Okay, thank you, Michael.
Yes, sir. Thank you.
I'll pass it, John. I think with the microphones, maybe I'll pass mine down to you.
Thank you, Brad. Report to start out with Los Lunas Community Program. Right at present time, number of individuals being served stands at 75, unduplicated count. When we review that consumer mix, we're running about a little under 50% are Jackson consumers. Roughly 50% have been crisis admissions to us, and a percent or two of just via freedom of choice, but the bulk are for sure either crisis or Jackson consumers. We also submitted both our staffing pattern intensity levels and individual consumer acuity levels to Leonard's financial office earlier this month, I believe. With that, we do have one referral of an individual that on crisis, it's going to require an individual residence that's fairly isolated and very heavy staffing patterns, so we continue to run into those type of crisis issues. We also, community practice review, the annual related to Jackson litigation was held, the exit conferences were held August 6th and 7th. That involved 15 consumers at Los Lunas. We had no immediate actions identified, and any recommendations resulting from those reviews we have followed up on. I did, at the Disability Concerns Legislative Subcommittee hearing the 1st of October, they did request a presentation by the Los Lunas Community Program. I did present and address the dental clinic issues. Rather than wait for questions on that, I addressed that. We identified where we presently were with that and what our intentions were down the road in terms of addressing any type of staff shortages there. That is a plan that was developed with Dr. Ray Lyons. Right now we are going heavier contract at the present time for hygienist and assistant. Ray's preference was to hold on some of the reclass situations as pay levels would be changing with that. He felt he would have a better chance of getting appropriate recruitment at new pay bands as they come out. Actually, the legislators were very supportive of the difficulty with dental clinic and the concern statewide with that. They gave some personal examples, so I felt good about that actually, but we continue to work on that, and we know it's a problem area. We are presently actually initiated tail end of last week and is the follow through this week on the Medicaid billing audit that's going on through Mike Mulligan's office and people assigned to that. They are presently there this week. I should be with them tomorrow. At present time, it has been. I don't know if you've had any comment, Mike, on that.
Not much. They just said that they're doing their work and they haven't had any issues yet.
But that's the way it was when I left. So I'll see you tomorrow. Some positive notes in terms of our intermediate care facility that is now occupied at 100%. So that is good for Los Lunas as a whole. We are dealing with one hospice situation, excuse me, of a Jackson consumer. So that is fairly high on the radar. Initiated one residential lease. That takes us to 24 residences in Valencia County. We are presently looking at one additional changeover and one new residence for some new referrals that we have. Excuse me. The Los Lunas Training Center, we were down the tail end of September with weather conditions related to power supply there. We were down almost a total of 72 hours. Responded well to that with our emergency backups, that sort of thing, but now we are totally back online. Related to that, we have additional interest in some of the buildings there by probation and parole, both as offices, record storage, but also as halfway residences for approximately 3 of the cottages that they're expressing interest in. That has been occurring over about the last 45 days, Brad, that they made the initial inquiry. Okay. Nothing past that point.
Keep us informed on that one.
We will. Regarding regarding accreditation issues for Los Lunas, we are hopeful that we can identify a mock survey individual or two that can come in and do that mock survey the first quarter of 14, with the tail end last quarter of 14 as a tentative
Yeah, working with you on
accreditation
that, or
timeline.
are you looking, that's such a specialized type of survey.
We're actually working with the CARF offices out in Tucson to attempt to identify some individuals. Hale's been in the loop on
That's a very specialized
John.
process.
that. Yes.
John, when you get that accreditation, you're able to then bill Medicare or Medicaid?
I don't think it will have any difference in our billing ability.
So it's more of status to the
Correct.
community?
Yeah. It's almost, I don't want to just compare it to a good housekeeping seal from back in history, but almost like a nationally recognized seal of approval on level of services being provided.
It's very important, we absolutely want to do that.
Sure. And that's high on our radar, Brent. Just related to personnel in general, we did do a employee appreciation barbecue in early October. Facility-wide training was held on abuse, neglect, exploitation provided by Division of Health Improvement. That was in early September. As with all other facilities, random drug testing implemented tail end of September.
Let me comment on that one too. That's another one like, well, it's different than the flu vaccination, but something brand new in all our facilities with the exception of Sequoia. There's some technical things and regs where we weren't able to get it started at Sequoia. But we're very excited about the fact, like private hospitals are doing nationwide, we've started to do both applicant testing and random testing of direct caregivers. So it's not every single person in each of the facilities. But it's been very common in the private sector, and it's a good and bad thing. It's challenging in an environment, some of these small communities like Las Vegas, and there's lots of others like that. Throughout the state, we have a drug issue, so you don't know how many of our staff are working impaired using drugs, and it was a little disconcerting to me. I guess maybe I shouldn't be shocked by it, but in our first round of random testing, we've already had, I think, 6 positives from our facilities. So that's just a small sample of random testing. We've had some pretty strong drugs in some of our staff, you know. So with applicant testing, now that we're putting that into our job postings, I think we'll dramatically see a decrease in anybody trying to apply for a job that's using drugs. But maybe it's just hopefully not indicative of that sample being indicative of the entire staff population, but that was a lot of positives from the first round at our facilities. So that did take me back a little bit, especially the types of drugs that were identified. So it's just something I'm very glad we're doing. We're all very glad that we're taking that to the next level. I think as we do it with our job postings now, with direct caregivers, they won't apply for jobs either. So it's just something we had to do. So I'm glad you brought that topic up.
Brett, one of the meetings when Secretary Varela was there, they were asking about what is one of the bigger, more pressing workforce issues in the state of New Mexico, and they mentioned getting New Mexicans, or getting folks to pass drug tests. And so there is a high prevalence. And I think
problem. And the types of drugs are kind of shocking as well. It's not marijuana, you know. They're really powerful drugs that these people are being tested and they're coming up positive on.
They have pretty short spans too, so probably may have been impaired at the time.
That's very scary, you know. So it's very good. This is an excellent quality improvement that we're doing, and it's going to pay off for us. And I think it's another way of showing everybody, that we've got a commitment to quality.
now, do you, is there like a process or policy in place in terms of what, there's random,
Yes.
I understand that component, but does, if an incident occurs?
Yes,
or
reasonable
those types of-
suspicion testing. We've been doing that all along, reasonable suspicion, but we haven't done the random or the applicant. We have been doing the reasonable suspicion.
And did you, I know we have to do this with FTA, it's a federal mandate, and they actually came in and they would set us up with a process for the whole selection of folks. Did you have to go through that sort of same level of random selection that stuff?
Yeah.
Because I know you always get that person that says, every time you have one of these, it's me that you call, you know, but it's random. So I don't know how random 3 times in the last year is. You know,
Right.
And then they start complaining.
No, it is random, and we worked out all that process, and it's just been in place now for not too many weeks. But
And do you guys have, are these staff that you have, are they union?
yes.
So you have to.
And we did have to negotiate that with the union. It was a long process of getting it in place, and Gabrielle and her team worked with us real closely on it, and what you see.
Safety sensitive positions can be union or non-union. I mean, it includes our doctors, our nurses who are not union members.
Brad, just a question on the self-disclosure, or self ID. When they come back, do we have a process? Do we treat them like any other employer? Do they have a special? Is there a need that we test them?
You don't have to talk to Alona about that. I haven't read that.
I'm not missing the boat on that. Then I mean, I haven't had anybody self-disclose right now, but there's word on the.
You just coordinate that with Alona in the labor
You'll get it.
department.
Yeah.
They can't self-disclose after they come.
No. But once they do and they've gone, do we treat them as?
Yeah, they have to do it now, but they can't wait till they get the phone call.
Sure.
Yeah. Oh, by the way.
Sometimes it seems
Right.
they're sharing with and go down.
That's right. Okay, John, sorry to interrupt you there.
Of the 6 that were discovered, what was the sample size?
I don't know the exact. It wasn't a huge sample size. The random testing, I think, over the course of a whole year, I think it's only 10%.
10%. It was roughly about a dozen on the initial random with Los Lunas.
The amount of positives relative to the number of total randoms was scary. That was a little high.
But I think it was over 100. Was it like 120? That's what you're asking, like 6% or something.
Yeah,
Somewhere.
yeah.
What they're doing is throughout the year they have to do 10%. So now that we're starting in the end, so what we're trying to do is every month that we're doing our randoms now, it's going to be a larger sample size than what we would normally do after
A little
January.
catch up. So we'll see between now and the end of the year, but at least the word will be out. And John, is there anything else you want to mention?
Just quickly that the Southwest Discussion Conference was held in Albuquerque last week. One interesting session was related to actually the state of Montana and the public health offices there that have gone to a consistent way to ensure that food and nutrition in the variety of whether they're group homes or residential settings in Montana, rather than individual agencies just trying to totally menu plan on their own.
Oh, okay.
To get some assistance there that would make sure that the nutritional basis of that part of it was at a high level for our consumers. We're going to take a look at that because we thought that was actually a pretty positive step health-wise for at least for our population.
I agree.
We did have one our main IT person is out on extended medical leave, but we are getting support related to that. IT needs out of Santa Fe, but so we'll be running a little short there, but we're getting the support we need at present time out of Santa Fe. So thank you to those folks.
Yeah, thank you.
That's it on me, Brad, unless there's questions.
Questions for John? And that, Lori, over to you.
Thank you. You have my report in the packet. I'll just make some key points regarding that. Census has been running around 121. We have been doing some advertising initiatives to get our name out there a little bit more to try to increase the number of people that are interested in coming into the facility. Along that lines, now that the surveys and stuff are over with, we'll be readdressing the VISTA program with the VA, and that VA program is their actual IT program that comes into the facility, and you're allowed to have X amount of licenses basically for the facility, and it's a view-only process of doing the medical records for those veterans that have services out of the VA.
Right.
And so it allows you to go in there and look at different medical concerns or issues and to ensure that they have the DD-214 and so forth. So I'm gonna readdress that again with the director at the VA here pretty quick.
And that'll allow us for a quicker turnaround for those residents that want to come in quickly. So
Great.
we're looking at that. Under the projects and construction, I'm very disappointed to report that we did get caught up in the shutting down of the government. We were in the process of getting our conditional letters signed by the Secretary of the VA the day that the government shut down, so it stayed on his desk and it didn't get signed, so that meant that the fiscal year closed without those signatures. So not only did Walla Walla miss out, but we also missed out on any of that funding. So it's, we didn't think we were going to get affected at all, but unfortunately those letters sat on the Secretary's desk. So with that being said, we do go on the FY14 list, the Priority 1 list, which started October 1 of 2013. So I sent an email to the Construction Grant Program Director in Washington to ensure that he was going to update the FY14 list to add us because we were taken off because we were going to get the conditional letter. So I'm like nowhere. So he assured me that he was redoing the list and that he'd get it out to me. So I'll keep bugging him on that. Hopefully, if we're high enough up on the list, we can go ahead and ask for that letter again. And
are they officially back at work today?
yes. Yeah, and actually the grant program didn't shut down. There just was no money flowing.
Oh, okay.
So they had a skeleton crew. Yeah,
crew
but they weren't doing anything because there was no money.
Essential folk, right?
Correct. Yes. So
They weren't doing anything, but they were there.
no comments. Under some of the other things that have been going on at the facility, you'll see my notes there. CMS, we had come in on August 22nd.
you had a lot of work going on there, didn't you?
We did. We had the CMS, we had VA come in at the same time, and then right after that we had Joint Commission.
Wow.
So on the CMS survey, when I wrote this report, we had not received the 2567, but I did receive that last Thursday. There was one life safety deficiency, and it was on the percentage of the load calculations for the generator. Our entire building, you're required to have 30% of your building on the generators to meet the standard. Our entire building is on the generators, and so when we're on load, it's at 100%. But we didn't have that calculation that showed it was set 100%. So now we have to do a complicated calculation on our sheets. We do it.
Right.
We did all the tests at the right time and everything, but that calculation wasn't there.
I think as you pointed out though, I mean, whenever I get a Joint Commission survey when I was in hospital business, when you don't get health deficiencies, that's all that matters.
I agree. If I don't have any health issues, I'm fine.
You know, they can run up all that other stuff all day long.
I agree. I'll take paper deficiencies every day. Absolutely.
Okay.
So we wrote that right away. We got that fixed. We had fixed it before they left, so that was an easy plan of correction to write. So we did that, and we sent that in last Friday. I haven't received the VA deficiencies yet, and that will be also life safety. There were no deficiencies on that. And then Joint Commission, there were 6 minor findings on some education and some training. So we're in the process of writing that. Gail sent me the template that she'd done, I think, a week ago.
Okay.
And so Donna's back now, so she's getting her team together to work on that.
Louis, they just did great.
Oh man, Lori's team.
We did a great. Yeah, the staff did a wonderful
Lori's
job.
team is remarkable.
They did
They're
great.
doing. When surveyors walk out of there and they sit down, and we're all sitting there like waiting for a baby, and they walk in and they sit down and look at everybody, and then they say, "We have no deficiencies." Everyone's like, "What do you mean?" But no, Lori has a wonderful team. And, she's
Staff did a great job.
great
Staff
leader
did
down there.
a long time, did a great job. And so we, Donna and I treated all them to pizza and a salad bar. We did a salad bar and a dessert bar here 2 weeks ago in the sports bar. So we invited all the residents and all the staff, and we did the same thing at night. So Donna and I treated them to that. So that was a nice celebration. I really enjoyed that. So we'll talk a little bit. I'll just mention the flu vaccines. We've already done the residents. The residents are at 95%. There's probably 2 or 3 residents that either have declined, and on those residents, the doctor goes and he consults on those to make sure that they truly understand, why they're declining and so forth. So, not that we try to talk them into it, but we try to educate them on the pros and cons of getting or not getting it. And we do our flu vaccines early because we do a booster for the residents. So they get 2 shots. So we do it early in the fall, and then we do one midwinter or early in the spring. So it catches, usually there's a second strain that comes along or there's a second surge, so we've noticed that in the population. So we've been doing that for a couple of years now, and it really helps, and we've had no flu cases at all from the resident population. Staff is always our challenge. I'm at about 60%, and getting that. We've had clinics. We do go around to the units when the staff decline. They have to go and talk to the infection control nurse and the doctor to explain why they are declining. And so sometimes we sway them our way, sometimes we don't.
Right.
We do an incentive program for the staff. I put an email out to all the staff to see what they wanted this year. Came back again, they want T-shirts. So those staff members that got the flu vaccine will get a T-shirt, and I provide those to the staff. So
That's
I'll,
great too.
you know,
Thank
make
you.
those. And
All right, quick
So that-
question
yes, ma'am.
for you and for every.
Yes.
What are the primary reasons why staff decline?
because it'll give me the flu. We
Yeah.
hear that all the time.
What can we do to combat that? I mean, that's absolutely a myth.
It is a myth, but
It's a killed virus. It cannot make
I know,
people
I know.
sick.
Well, and most of it is the clinical staff. It's
Oh,
the
yes.
nurses.
Oh, yeah,
It's
it's
the
the
nurses
nurses.
that don't
The
want to
nurses
take
is your
it.
largest population that will not take it, even
That
the
is
ones
correct.
that give the
Yes,
injections
that
are the
is
ones that will
correct.
not take it.
Mechanics have the worst cars.
Yes.
Roofers have the worst roofs.
absolutely.
That's
It's
our
a
part of
challenge.
this group.
They say that it makes them sick, not necessarily that they get the flu, but they feel poorly for a couple of days and then.
Yeah.
Yeah.
Right, I think.
And a lot of times they equate that
Psychosomatic.
feeling afterwards with it gave me the flu,
Yeah.
and it's not the flu, you know. So it's really hard to.
I think the education prior to people being chased around with a syringe. I think all the education that they can provide. Lori started when I was down there. She was putting up posters and very clearly saying the facts and myths about flu shots. She put them every single place, every nursing station, every workstation, and reaching out that way to employees. But I think they still have this
I like that in all the hospitals
Send
too.
Mike on a tour.
yeah.
Mike Lennon.
Yeah, sure.
Yeah.
That's an idea.
Brad, we do have direct care staff. I mean, just to echo the point that are going to take their lead from our clinical folks or our nursing medical staff. And if they're not,
It's a little worrisome if a nurse won't take the shot.
It is worrisome.
That really does make people, yeah.
Absolutely.
But you have people that have that ingrained belief that there's something about it that they just.
Right.
it's-
We have the same problem in all the
Re-education,
hospitals.
re-education,
Leonard and I, when we worked in the hospitals, they're the same way in New Mexico.
They hear most, more than anyone, they heard the education.
I think they've never gotten the flu. If you've never gotten the flu, you'll take 2 of those if they.
Yeah.
I'll tell you, it's.
Well, they always say that.
I'm sorry.
They get the flu when they take the shot.
Yeah.
They don't take the flu.
That's what they do. And along those lines, all the residents get the memo back also. So
Good.
that's usually we're at 95 to 99%. A lot of times that other 1 or 2% that they are just allergic to it, so we back those out of the numbers. We're in the planning stages now for Veterans Day. Veterans Day will be November 11th, of course, starting promptly at 10 a.m. Invitations have been sent out to everybody. So everybody should have gotten their invitations and have that on their calendar. We'd appreciate any support if you want to come down and have a really great day and a nice meal.
What day of the week is that?
It's on a Monday. I think Monday is November 11th.
So get the clock in, coming down.
And if you haven't ever been, I can say I've gone a couple of years, and
It's a big deal.
it's not only, I mean, it's just prime, they have a flyover.
It's really great.
It's just, you see the veterans out there in all their, it's,
The Secretary Hal is there.
it is.
He is, but he can't come this year.
Oh.
So I think there'll be a designated GPS that'll be coming down. So.
Good.
And so we're working on that, doing some stuff on QAPI. I am happy to announce that we have a new QAPI nurse, so a
That's
quality improvement.
Well, that's real big.
Yes,
That's
she
very
started
important.
Tuesday,
That's
2
very
days ago.
important.
Did you take her flu shot?
I haven't put her on that one yet. But her name is Lori Kelly, so she comes to us with lots of experience, so we're really pleased to have her on board. And there's just some highlights on some of the MDS stuff that we continue to track: restraints, falls, and pain. Key things that we were doing before Joint Commission came, and so we had a lot of data for them, and I think they were pleased with that. Some other things that we're starting. I did another team, a different team for the hiring at the facility. So I have a team now that's put into place that includes an HR person and then another office staff, as well as the department that is doing the hiring. And so we have this team concept, and as they're going through the interviews, each person is taking a piece of the puzzle and doing that piece so that by the time that interview is done and shortly thereafter everything is done that can go to HR, So we're not having that time lag with,
Right.
with checking the references and
Yeah, I
checking
know,
those things, because it's
trying
hard.
to work with you on that.
She had to cancel her trip down to the facility because she had some employee turnover and stuff, so she's waiting on that. But we're happy that that process is in place. We've got 2 new nurses that have been hired this week. I have 2 internal transfers, 2 nurses, and I've also done 6 CNA packets this
I think
week.
the facilities overall in DOH are the ones that have been the most aggressive, in hiring, thinking out of the box.
Really trying to do different things, because we know it's a cumbersome process, but once we get, if we can get that process in place, and I've given HR the goal of getting everything off of their desk for that hire of a 2-week period. So we're really zealous. But so far,
I know, as we know, we never can use that. I know it's life it's what it is, but T or C is not the easiest place to recruit.
It is not. It is not.
Every time you recruit somebody, it's a big win.
Right, and so when people come in and we have HR help them with the application, we have a computer set up there, we walk them through the process. I have a really good HR person that does not let anybody leave until they've applied for a job. So he's really great, so I'm really glad for that. And then next week we will be starting our strategic planning session for FY14. We have put that on the back burner while the surveyors were here. So normally we start that in June and July, but we're just a little bit behind the curve this year. So.
That's fantastic.
Yes, we stand for questions if anybody has any.
I just want to comment that I'm always impressed when I go down there, that facility, and working with the surveyors, and you know that team is working really hard, and the surveyors can't even come up with with a finding, and the team does work very hard, and it's a reflection of their leader.
It is. It's true.
It's a very nice facility. Good job.
Question. With regards to the type of resident.
Yes.
Are they pretty much the resident that doesn't leave other than?
Yeah, I would say probably 90% of our population stay with us. I have residents that have been there for 20 years.
And is it because of the type of problems that they have, or is it the lack of resources and supporting the community?
Well, I don't necessarily think it's supporting the community. I think a lot of our veterans come to us that maybe have family that live back east or don't have family locally, and so we become their family. So they come and they live with us. We take care of them. Sometimes their medical conditions don't allow them to go back into. Sometimes they do. Sometimes we'll rehab them. I've had several that have come in over the last couple months. We've rehabbed them and sent them back home, which is what we prefer. But sometimes they just don't have family around to take care of them, and we're there to.
We're working with the VA, the federal, and I guess the
VAMC,
to institute the veteran self-directed component, which has kind of gone through the first phase, which is to try to set up the infrastructure, and we've picked up McKinney County as an area there that we would work with. But if we're able to get this thing going, the intent is that the VA would grant us the opportunity to roll this thing out statewide. And so I'd like to maybe come down and meet with you, talk with you, and just kind of pick your brain on that expertise.
Our doors are always open.
And I don't need to apply for a job.
That's fine. I'll just let you do it. I will make you go upstairs.
Just wearing your badge so they know you're.
That's right.
I have no badge.
As a military guy, you should go to the Veterans Day celebration. It's very cool.
It's been very impressive there.
Yes,
Next.
Thank you.
Janie?
Okay, I'll start with our statistics. For our medical rehab unit for the quarter, we had 31 admissions and 32 discharges. The average census is 4.5 patients per day, and the length of stay is about 14 days. On the chemical dependency unit, we had 79 admissions and 76 discharges with an average daily census of 16 and an average length of stay of 19 days. The rest of the statistics there are the outpatient or the inpatient visits by the therapies, and we're still continuing to try to build our outpatient program. For hires, we had 7 new hires in the quarter, and I just was told yesterday that our biller has accepted, so she starts the end of this month.
It's a challenge for you also, though. You're especially getting clinical staff. It's real hard to get nurses.
Right. We're just not competitive with the 2 local hospitals, and new grads would much rather go for sign-on bonus. So we have a difficult time hiring nurses. Right now, we're running quite a bit of contract dollars for nursing staff. We've had 2 mock surveys. The life safety survey was August 26th and 27th. And in that survey, the building, because it's a new building, did wonderful. But we've got all of our management plans that require governing board approval, like Troy's. We had some suggestions on changing those and the reports that go with them. So we're in the process of redoing those, and we'll bring them at the next governing board.
All right, thank you.
On October 1st through the 3rd, we had the clinical and the leadership side of the survey. And our priority focus areas are information management, physical environment, communication, and credentialing of practitioners. We haven't received that report yet, but we got a lot of good feedback back from her too. They were both excellent people to work with in the Joint Commission process.
And I might mention too, give Cal some kudos for that. We've never had mock surveys really before.
Right.
We haven't had the ability to do this before, and so in the last year, how long we've been doing this now, it's really been a quality improvement just in doing all that. We have a quality team in place now we didn't have before, which Louis is a big part of. And then Dr. Dorman's a continuation of that with his 12 years of Joint Commission experience and all his national expertise that we're just going to continue to greatly improve in quality of care and patient safety. So we've got a lot of internal resources that the Department of Health never had before.
Yeah.
So this is a big, big quantum leap, I think, for the Department of Health.
Oh, I agree. And the documentation that they gave us and the examples of ways to write some of the plans has been wonderful. It's just getting it all done.
Right, it's a lot of work.
Yeah.
Yeah, along with the mock surveys comes a lot of work.
Yes.
It's after they leave, you have.
But I would much rather do it now than after the real survey. On our medical rehab unit, our goal is to average 10 patients. We're monitoring our referral sources and working with the local case managers, trying to increase that. Part of the issue there is our process, our admission process, and how long it takes us to make a decision and get them in. So we're focusing on that and trying to cut that down. On the chemical dependency unit, 16 was the average that we were wanting because we only had 2 counselors, but we contracted 2 more in. That started yesterday, so we're in the process of increasing census on the CDU program to 24 to 26 patients, and we only have 28 beds there, so we'll be running pretty much full capacity on that unit. For flu shots, they're offered to the patients on admission. The majority of the patients coming in on medical rehab have had them at the hospital that they're being transferred from. The CDU patients, about 50% of them have taken it when it's offered to them. A lot of them have the same concept that they'll get the flu, and I don't know that that you can do much educating with them on convincing them that's not the case. And we have a clinic for staff set up on October 29th.
Okay, great. Good, thank you, Janie. And Jeremy.
Well, thanks again, Troy, for helping us out. I got my flu shot. I just want to make sure you guys know. And I'm still feeling the little effects of that. I got it Tuesday, so all this talk about retreats and therapy things. Anything in there about massage? I'd like to join you guys. We're working on a number of initiatives. As it was mentioned earlier, of course, we'll be the latter half of that Joint Commission initiative, so I guess I'll be probing you guys' brains, see how much you took a hit on so that I can help prep on what they're looking at. And Mr. Mike Brown has been working with us closely too with some operational improvements and around our power needs and different capital projects. And we still working with IT as we still want to move forward with our electronic health records, but once IT gets some of their other priorities going, then we can continue on with that. But with the surveys, we officially in the past month or so, officially received our 5-star rating from CMS from 4 stars from the previous survey, previous fiscal year. So I was real proud of the staff and team in around that. It looks like Lori, you're definitely in that arena as well.
Should be.
So, so I know how much effort goes into that. So it's something I was real proud of with our staff. We've got a number of things in regards to their staff. Just a highlight note, even though it's not part of our HR discussion here, but we've heavily pushed to promote from within, especially our CNA staff, from our basics up to operational levels, so that we can continue to create that pipeline. And with a number of initiatives that we've done, we've successfully done that, and we've actually going to run another CNA class here in November, and we hope to have 10 in that class. We just pulled the list the other day. We have 26 applicants. So
Wow.
Word's getting out that
Wow, that's fantastic.
Fort Baird is a place that you want to look at working at. We are also in part of our strategic planning process. We're going to kind of really tear that apart and really build something there. We're going to use the Malcolm Baldridge approach, and we're currently also identifying future complementary services for expansion with that strategic planning process. Part of our employee appreciation, we've decided to incorporate our wellness program as part of in boosting morale and getting staff involved in different things. And I will say we just did our first 3-month challenge, and we finished that, and actually the updated number here, it says through the first 2 months that there's 344 pounds collectively were lost. We had 63 participants and divided into 3 teams. We actually lost collectively 466 pounds collectively. So we did a number of events in and around all of that. I don't want to bring this up, but we can add this to the notes. Team J won that. So, but it was great. The staff really loved this. I think they're trying to do something on their own going forward, and maybe we'll do something again in the spring or something when everybody has their New Year's resolutions.
Yeah, I want to commend you and your staff for this. It's a model program, and these results are astounding, absolutely astounding. And in addition to being the right thing to do for employees, there is an enormous amount of research now that shows that employee wellness increases productivity, it decreases absenteeism, and it increases something called presenteeism, where people are better at their jobs when they're at work, when they feel better. So it's an economic boost to have an employee wellness program, and it's one of the things we can offer when we can't offer competitive salaries to the private sector. We can offer something like this, and obviously it's very popular. And as the Department of Health, this is one of the things that we as a leadership team expect, is that we're exemplars for the rest of the state in terms of modeling wellness behavior. So thank you. This is absolutely wonderful.
Yeah, we definitely believe you should probably practice what you preach. If you're trying to take care of a lot of people, maybe you should model that healthy behavior. But we factored that in because we noticed it does cut down on your sick leave, and also, as you said, the call-ins and different things like that. People are more vested, and also your turnover. So you kind of reap a collateral.
I would just recommend anyone who's trying to develop some of the wellness programs that you consider some of the legal issues that might be present for that if you're collecting any information. And also, we do have a lot of experts, obviously, in public health and those kind of initiatives. And I think sometimes the facilities are kind of isolated, but we have a lot of experts within public health division that can help develop those wellness plans in a safe and effective way for long-term, keeping the weight off and that kind of thing. So I know that they gave a lot of information to us when we were trying to develop stuff in Santa Fe. So it's important that you lose weight in a healthy way and a way that you can maintain it.
Sure, and I appreciate you bringing that up too, because there's a number of things that have, and if anybody is thinking about doing this, if you want to get some of the good, bad, or indifferent, please let us know, because we kind of were fumbling through it initially, and we realized that there's certain things that we have to ask for with the GSD, and then we got involved in legal there, and we were able to bring in consultants to give either demonstration or motivational talks and different things like that we sponsored, personally, not the state, but the different groups have brought in, and it was really well received. We wanted to make sure that we didn't impact or create any situation that would be harmful or potentially harmful. So we were pretty conscious of that, but I think we worked out most of those kinks.
It'd be nice if we could, hint, it'd be nice if we could do that in our facility, wouldn't it?
Everybody gonna show up to work.
Gabby, once Secretary Ward left us, we went back to drinking, smoking.
And that.
And right at one time, there was a wellness committee that was looking within the Department of Health, that was looking at setting up some initiatives and setting up some healthy habits of work. So it might be something that's timely.
Right.
There's still remnants that live from that. We have a yoga class that goes on over at the administrator's house at the lunchtime where staff can go, but you're right, you have to involve GSD, get the permission from them to make sure that this activity is going on, so to make sure that you have all your ducks in a row, and then you have to get the physical clearances or some kind of waiver from the staff if they're doing the exercise programs away with the weight.
Yeah, that would be helpful to get that. Maybe that might be something that you guys can do in terms of for others, because I had not hot Zumba, just a Zumba, and I was like, I don't think GSD would let me do it, and all the risks, and before I knew it, I was pushing back, and I kind of felt bad, but all I kept thinking of was liability. And so it might be helpful for other programs if there could be something like, here's what is and what isn't.
Well,
Myths and
timely to what we're seeing is the food part. That was a big part of our wellness committee as well. We actually put together a number of things where people would do healthy recipes and stuff like that. And we actually started a salad bar Wednesdays that the staff could, in lieu of what would be on the menu, or in lieu of the employee menu there, is they would just get their meal ticket. And that was the most heavily attended. Every single week, without fail, we sell the most tickets by almost double on those days for the healthier food choices. So
you guys are in Las Vegas now, so it's deep fried something. I told you. Never with green chili.
Or we're doing between.
I like butter myself.
Show us your
But not to change the subject, I'll continue on with the rest of the report here.
Finish up your report then.
Yeah, the census, which was reported, we wanted to increase the census between 130 to 140, and we've done that successfully over the last, July through September. We're currently at 136, and that fluctuates a little bit between 135 and 140, depending on the acuity level of the patients we're accepting. We did take a big chunk out of our referral wait list initially. That is creeping back up again because now that they know that we're opening our doors, there's just a lot more people
Like
knocking.
25 or so? Or something?
I'm sorry?
Is it 25 or?
Yeah, I think it's 26 at the moment. But that's been, to me, it's been successful. I think with the Medicaid expansion, the only thing we're going to see is just increased referrals.
Right, so this is all predicated on being able to hire the staff,
Mm-hmm.
and that'll allow you to bring more of those people off the waiting list.
Some of those reclasses come through. I'd like to offset that with some of the contract nursing we're currently using. Yeah, we can definitely look at that. The marketing piece, we continue to be active in the community. Most recently, we were at the Memphis Health Fair, doing some BPs and showing some stuff there. Just a note here with under the medical and clinical, the outcomes. We continue to do well with our ulcers as far as being below in the state and national averages, and as well as with our falls with significant injury. Part of the initiatives that tie in with the whole employee appreciation and improvement and retention thing is improving our management team skills, and that's at all levels, and we're heavily vested with that, and actually talking with Tula and Melissa and a number of groups about that. And if you guys actually have anything going on, I'm a sponge, so I'm willing to hear everything and anything you guys are doing as well. One emphasis is that I want to make sure that our wound care specialists are certified and trained, as well as our MDS coordinators. So we're actually having them certified as well. Regarding the flu shots, we did get our vaccine last week. One of the things in the previous year, we had a 95% vaccination rate for employees and 96% for residents. So we actually did pretty well. We looked to maintain that. And one of the things is the educational piece that was mentioned. We do hand out an informational sheet that kind of goes over a lot of that stuff, both the pros and cons. And we just started that for the employees, so we'll hopefully get some of these results rolled out soon. Some of the other stuff is just the basic stuff that's ongoing that we've reported previously with our dental and x-ray stuff. And I had mentioned earlier with our information technology, one of the heavy things that we're looking at is also the cameras as well, but that's part of our CYFD project. Finance so far through the first quarter, we've done fairly well with the revenue collections. We're at 94%, and one of the things that we're helping with our cost, we've actually dropped from the FY13 fourth quarter, we dropped 18% in our overtime costs in the first quarter of FY14. So we've continued that trend. We've set up a committee that monitors that on a weekly basis and reviews that. Yucca Lodge, in the census there, we're trending slightly higher than in previous years as far as the total clients that we ultimately served. We served 35 for the first quarter, and traditionally that we served roughly around 117, 120 a year. Right now we're looking to maybe be around 140 or so or more there. The HR, the last part here, we've had 16 hires in between July and September. That's going to actually go up somewhat in this next quarter here. But most notably, we have officially hired and successfully accepted a DON. So she starts actually this Monday.
Great.
So,
looking forward to meeting her.
Absolutely. She'll be here or in the future facility meetings, I think.
Sure.
We're actually working on a special orientation process for different things based on not just the normal paperwork and, this is what your job is, but what the actual kind of flow of the way the programs are and different initiatives that we want to achieve.
We'll probably have one of those facility meetings in November before the winter sets in, but we'll have another one of those.
And we'll be able to meet her then. One of the things we are also working is improving our collaborative efforts with the local nursing school there. And one of the things we'll probably want to talk with HRB about is how we can capture a lot of those that are graduating from the area and actually retaining them in the area and especially utilizing them in our facility. So we're actually going through a number of initiatives with them and how we could work that out, but that's going to tie in with the DOH as a whole. Some of the things we did do a job fair and employee recognition. One of the things we just recently did was a little bit delayed, but based on the success of our surveys and just different things, we tied in employee appreciation days where we actually, our events committee raised funds as well. Well, basically the leadership sponsored the number of activities and stuff which tied into our wellness activities as well. And if anybody has any questions, I'll be glad to answer the best I can.
That was great. I know, sure, go ahead. Good job.
I have a couple questions.
Sure, go ahead.
On that wellness program, do you have stuff that's already been approved by OGC that the other facilities can plagiarize?
Well, it's specific to depending on what you're going to do. So, depending on who you want to bring in or what activity you want to do, then you would have to.
So you're just talking about individuals coming in to present to
the
staff?
wellness committee, from my understanding, if you're just going to form a group, is okay. But when you start bringing in people to do either a demonstration or training or speech or anything like that, or if it's going to involve.
You got a fun run too, didn't you?
Yeah, well, it was I want to call it a speed walk, which got quite hilarious, I have to say. But it wasn't anything that would result in extreme, extraneous, physical activity that would create a health issue. But from the legal standpoint, it was just making sure that we got the paperwork that it was approved or it was known.
Okay. So basically, anybody else that wants to do anything should just check in with Gabrielle and the team.
Right, and there was a group that we worked with at GSD, and I can pass on that information to everybody as well. That if you just want to cross-check it with Gabrielle.
Why don't you forward that to everybody?
Sure.
And then the second question I have, on the nursing leadership, is that something you're doing specific at Fort Verde? Are you sending your nurses to?
No, I have a nurse leadership team meeting on a regular basis, and we discuss a number of agendas that we need to talk about. And we also do educational sessions so that they start learning management. We are actually in the process of looking at bringing in formal management training so that they can build fundamental building blocks, because they graduate from nursing school, they inherit these positions.
So I'm interested in that too. That's why I was wondering for somebody you were bringing in.
Yeah, we will be. Yes.
So when you do, can
Absolutely.
we come?
Can you serve with a group?
Like at no months?
Absolutely. But it's not. It goes beyond just some of that too.
Since you're already paying just a few more chairs.
It's going to go beyond just nurse management, because I mean you have a number of different department heads, but we're going to build up a core, and then we'll build out the specifics from there. So we're creating a curriculum.
Okay. So I'm interested in getting some nursing management
Yeah,
training for
Great.
myself.
Absolutely.
That's what's good about these meetings, is sharing all this stuff. You know, it takes a little while. The next two reports will be briefer ones, but this information sharing is the most important part of what we do.
Thank you.
Where we get the opportunity to hear what everybody's doing. So I guess, if I could, I'll ask for a motion to approve all 7 administrative reports as a group.
Brad, before we do that, is it possible, I don't know if
Oh, yes.
everyone has the opportunity or had the opportunity to look at the performance management report? I know it got bound last night, sorry about that, I saw Gabby reading it, but
Didn't read it all, no.
if I could just quickly go over that and we could include that in the approval, so I have that in the minutes, so it's meeting our joint commission requirements.
Sure.
As part of the FY13 year end, we did our performance management report. You guys have it in front of you. The stars show that we were in compliance and met our goals. The check marks mean that we still have some opportunities for improvement. As you go through, there's some with more stars in than others. Part of our retreat, we're actually going to go over some of these, and the people are going to get up and present what they did to be so successful in meeting these goals. So you can look through there and see the inpatient clinical care documentation. We've already put some stuff in place that number is looking better. We talked about the norovirus, what we did for immunizations. There's all your information on influenza. But I think the seclusion and restraints, whenever we look at that, we don't only compare to ourselves, we actually look outside. And in the latter pages toward the back there when the graphs start up, Western Psychiatric State Hospital Association, we compare ourselves to all of those state psychiatric hospitals in seclusion and restraint, staff injuries, which is a big focus we're working on now. All the other hospitals in our region are, because we have so many staff that get assaulted by patients. They're very aggressive, and so a big focus in the Western Hemisphere, actually nationally, is looking at preventative measures from that. So if you turn all the way over to the first graph, it says restraint rate, hospital total. Kind of looks like, it doesn't have a page number I noticed here now, but it looks like this.
Right.
Now it's the one before that one, I think, Secretary.
Right here.
Keep going. Yes, sir, that one there. Restraint rate, hospital total. So you'll look down there in regards to the restraint. New Mexico is a little to the right of the middle. You can see New Mexico State Hospital. We were at 2.35 compared to the other facilities. The next page shows you where we fell out, just in a different format of how to read that graph. That we were 4th from the bottom, which is actually the
Why? He's going up there.
Somebody want to be on the beach.
We gotta restrain them.
In our, if you look at the third graph, or it's actually the second, it says restraint hours, hospital total accounted for by the top 5%. What we see is out of our restraints, 90% of those were accounted for by the top 5% of people. So when you take the total number of individuals we had, you're looking at 1-2 individuals that account for 1% of those restraints. And so that's you want to be high on this number. So showing you're not just restraining everyone, you're only restraining the ones that are in need of it. And then our seclusion rate, we're also doing really well compared to others. You would not want to be in Montana or Wyoming.
That's why Wyoming has such a low restraint. They seclude them.
Then you'll see that. It's actually, that's what will happen. They pick one over the other. So yeah, you can go back and compare the two graphs. Ours are low in both regards. And we account for 80%. If you take the top 5 in our seclusion, about 80% of our individuals are accounted for in that top 5%, showing that that's also a very small number that's actually accounted for the seclusion. So in essence, it's good information. Even though we didn't look good for the smoke-free facility compared to everyone else, we looked really good in regards to our seclusion and restraint data.
That's fantastic.
And at the very last, on the other side of my favorite color, lilac purple page, just talks about it's a summary evaluation, so you can look at it in what areas and PI programs that we have going on.
So would you like, Troy, in addition to, you want me to do that as a separate motion, or as part of the?
I think it could be as part of the HA, hospital administrators reports, and the performance management report for NMDOH, so it's spelled out separate in the minutes.
All All right.
Because when the Joint Commission comes, they'll ask to see that in the governing body minutes.
So you're making a motion?
I think there may be questions.
Well, I just have some comments,
Okay.
if that's okay, but they're not gonna have you change anything, it's just that for this employee immunization data, I think that would be helpful if you can make sure that you share this information with epidemiology, in addition to the new forms that are being tracked. Because I know they're trying to make some efforts for all of DOH, especially the activities that you're doing, so that maybe some of those can be implemented throughout the department and other facilities.
Would you like him to contact Mike about that, or?
Yes.
Mike Landon? Good
And
idea.
then you have a patient perception of care, and you talk about a survey that you did. So I was just curious where that survey was created, if you borrowed it from someone else, if you created it here.
It's actually one that we created internally. We're looking at that Whipshaw conference. They actually have one that NRI develops that I think Joint Commission is actually going to adopt. We're looking at utilizing that measure so it can even be tracked by NRI compared to other state facilities.
Okay, that's a great idea. I was also thinking of our epidemiology and the survey unit we have within DOH. Again, just reminding people of the resources we have within the department as a whole. If you have surveys that you develop, they're a good, place to run them through so they can see if they have any statistical significance, and they can help you formulate the questions, those kind of things. So just keep some of those resources in mind when you're taking those kind of actions. And then the care unit, talked about a lot of activities we have at the care unit. I didn't know if it was possible. There's been such a positive response to the sort of graduation ceremony at Sequoia Adolescent Treatment Center. So I didn't know if you wanted to talk to Sequoia about maybe borrowing some of that. I know folks do leave from the care program, obviously, and I don't know if there's
Yeah, we do a graduation ceremony. We don't do the balloons. I mean, I like that idea. We don't do the balloons. We do a graduation ceremony.
They're actually, they sit around the table and each person tells them goodbye.
What they got out
Yeah,
of being there.
they have to do a mask, and the inside of the mask is when they came in, and the outside of the mask, and it's their actual face, is how they're leaving, and they tell a story about it.
Very good.
And then the staff get to give feedback to the client. The client's giving you feedback. He says, hey, I'm sorry for punching you that daughter. And it's actually really emotional, to see them participate in that. But it's a very
I'd like you to say something if you are, because we do something similar.
Okay.
It's a little different.
Then on the section for FPP and OPCP, I would like to see some inclusion or recognition of the need to have OGC's involvement in this process and the recognition of the state personnel rules and processes.
Okay.
You're talking about how you're doing the focused reviews and that kind of thing. I think that could be tied into the performance improvement plans that you sometimes have to put into place for state employees. So depending on, whether they're a state employee or a contractor, just some recognition in that process of the fact that we sort of have a dual system, so to speak.
This is another area where Dr. Dorman's an expert, is on that topic.
And that's where this PI team, the FPP, OPPE team is from, that survey. They actually put together a performance improvement team with his recommendations to work toward getting that done. But you're right, there is a duality here with the SPO and the medical staff bylaws. And good
Point, Gabrielle. Troy, let me ask you to make a motion.
For all up or just for this?
For the whole thing.
Okay, well, I'd make a motion that we approve the hospital administrator reports as presented, and inclusion of the performance management report for FY13 for NMDOH.
Motion to approve. Okay, all in favor? Aye. Opposed? Okay, motion passed unanimously.
Thank you, guys.
I know as we get close to 12 here, or it is 12, we have two brief reports here, and then we would have some closed session. I know I can smell a lot of food behind me here, but I think we will still be done by 12:30 easily, but I want to go ahead and just, if we could here, finish up our open session here. We have the next item on the agenda is the financial report, I believe, with Leonard.
Okay, the schedule is a handout, the package that you received. There's really only three key items. And I'll let you know that we do work with all of your financial directors as we prepare these. There's give and take throughout the period on items that need to be addressed. So the items that I thought were critical is if you look at the other revenues, you see that the projection is less than the budget at this time, but I would not have a concern. That really addresses that the first quarter, our collections tend to relate to the prior period. We're applying it to AR as opposed to revenue. So we tend to see a bigger number in the fourth quarter because that's when we're accruing the accounts receivable. So it is a little low, but I don't think much of an issue. The next item is on our contractual services. If you'll see that our projected is higher than our budget, and I'm just hearing this from each one of you as you report that we are coming to a realization that if we're going to be able to provide the services, we need to provide that. Often we're going to have to use contract services, and so we're working again with each of your finance directors, and there's going to be a bar sometime in the future where we're moving between categories from the salaries and benefits and into contractual services. If you will look at the column for the FY13 actuals, you'll see that, and this is kind of brief, and it includes all of our services. So some of the items do not apply, but the total surplus deficit that we're showing, which is conversion, but that's not a total amount. Some items will be excluded, but it's approximately that. You're seeing that we're about $6.7 million for the year. My view of this, I think in some of the areas we tend to consider that reversion is maybe not the best things, but what I have come to understand that reversion in this area tends to be that you all are successful in capturing revenues from other sources, and to me that's a good thing. So between us kids, I say that we applaud it, but and encourage you to continue to improve in that area. I think that's what we want to do, but it just ends up that it is in reversion. I think unless you had any questions, those are the items I wanted to highlight. Thank you.
Okay, any questions? All right, I'm asked for a motion to approve the Program Area 6 Facilities Management Financial Report.
So moved.
Second.
Good.
All in favor? Aye. Opposed? The motion passes unanimously. Two more items. Credentialing report and just open comments. Louis, can I impose on you again to give us anything we need to know regarding their credentialing? I know we have a lot of them this time.
Yes, we had
I
quite
got
a
them
few.
over earlier today.
Yes, we had our meeting yesterday, and we're looking forward to Dr. Dorman to come in December, so that our next credentialing will be in January.
Yes.
So things hopefully will start working out a lot firmer. So we had several from NMDOH, and I want to talk a little bit after we talk about the candidates about the process and the company that we're using right now for primary source verification.
It's HSC, I think?
Yeah, and get some feedback from y'all and let you know where we're going to go with that. But Dr. Bruce Anderson, he's a podiatrist, and Ruth Flores, a CNP. Julie Moore, she's the pathologist that consults with NMDOH for their laboratory and M&M process. Alan Franklin, she's a psychologist, initial appointment. Desi Sotsu.
We call her Dr. Desi.
Okay. Dr. Desi, also a clinical psychologist. Dusty Humes, clinical psychologist. And Dear Boxman, CMP psychiatry. Dr. Knightley works at, is it CBS?
Who's doing forensics?
Psychiatry. Dr. Keith. There's a reappointment. And Maria Mina, it's a reappointment for psychiatry.
Karen Lee.
I'm sorry, Karen Lee. And then Dr. Olivares, Melakieres Olivares. He's a reappointment, a medical doctor here at NMDOH. Carol Sauer, and She is a psychiatry contract,
She's contract, yes, her initial.
and Barbara Choji is a reappointment.
And Troy, just in terms of it's amazing that you found 6 new ones. That's pretty impressive. Were there any issues discussed at credentialing we need to know about, and any of the NMDOH items that you need to mention to us? Or?
There were some previous issues that have been resolved,
All right.
and the team was ready to move forward with the full
Okay.
credential.
All right. I'll let you finish your report, and we'll just approve the
Okay.
credentialing report as a whole.
Oglesby is a PA practicing at Fort Bayard, and William Mindorf is the doctor, the dentist that's contracted over at Sequoia.
Any issues with either of those?
No.
Okay. All right. So would you like to go ahead and make a motion then on the credentialing report?
Sure. I would like to make a motion to approve the candidates that are listed on the credentialing report.
Second.
All in favor?
Aye.
Opposed? Motion passes unanimously. And I know you mentioned that currently we use HSC. And many of the hospitals in the state of New Mexico also use HSC, I believe, as well, don't they? Or,
Yes.
I know Leonard's probably much more knowledgeable about this topic than I am, but there actually is an alternative to that?
Oh yeah, yeah. There's a couple, including one that is starting up in Las Cruces, locally homegrown business that's starting in Las Cruces. Our main problem is that the communication with the company is really, really bad. They don't get back to us in time. Their turnaround time from the time you submit a packet to the time it comes back to the facility is quite extensive, and it's gotten Troy into trouble a bunch of times.
It can be 6 months or longer. We've actually started expediting all of ours, trying to get them into these quarterly meetings, so we don't have to have the emergency meetings. But when you expedite, you pay more to try to get them in.
And so I worked with, of course, Nikki. Troy was the one who really shed light on some of the issues with that company. Then I worked with Karen Carter over at Veterans Home, who's also stated that there's a little delay. Jose Gurola over in Roswell is experiencing the same. Over at who else was experiencing? Anyway, so I talked to Maggie.
Maggie Gallagher?
Gallagher. She's saying that there are some problems as well. Dr. Novak yesterday also mentioned some of the issues. So now that Dr. Dorman comes, it's going to be one of our first agendas is to get on the phone with the company and say.
Right, we'd like to include him in that.
Absolutely.
What would be the best alternative? What is the alternative?
Well, to do it in-house is really, yeah. And you have to register purchase certain computer programs, and you have to be certified federally to get into some of these databases. And so, and plus, Joint Commission requires that an outside person do your primary verification.
Right.
So there are options. There's Dr. Novak yesterday mentioned that QSHC, QAFC, yeah. That's
Kathy, do you have a comment on that?
I do, and the comment comes from doing kind of the provider readiness review for Centennial Care, and 3 out of 4 MCOs in the state use a different services, and I'm not quite sure of the names, but I thought it was.
They're not using HSC?
No, the only one that's using HSC is Presbyterian, and they've made the commitment to go to this other one, which I think is CAPS, and I can find out the actual name.
Well, that must be a reason, right?
Right, and I think the reason has been, and I know Medicaid has used HSC, but everybody's sort of looking to switch to this other company.
Did you give us that information? And
yes.
Dr. Dorman arrives, we'll certainly initiate those conversations with HSC and see if that relationship's, fixable.
Yes.
If not, then
HSC used to be really reliable and timely. They switched to a new database, and I think that was their downfall because they had so many glitches and bugs in that they were having difficulty getting us the information we needed.
Well, and I think, I'm sorry to interrupt Troy, but when they switched their computer program, they lost so much data that organizations were having to re-enter the candidates that were already in their database, and it was taking them so long. But if you can forward any information to me,
I'll take that as an action item and get that information to you.
Great, we'll make that a priority in December.
Perfect.
It would be helpful to establish a contract that both parties agree on, because currently we don't have a contract with HSC because of the language, and so there's no accountability that we can hold them to because there's no formal contract. It's a PO when we do the service. We do it. It would be great to have that.
And the other, I'm sorry again, but the other piece to that is looking at a contract at the DOH level as opposed to every facility having their own contract. To save some money.
We agree with that.
So that's something.
Great for PhD as well. All right, well, thank you.
Thank you.
The last item on the agenda is the open comments. I think, Ruby Ann, are you out there? I think I hear you out there.
I hope you haven't been hearing me.
We have.
Yes,
I don't think I have any comments. Thank you.
Yeah, okay. Great. I had mentioned earlier, Ruby Ann, that I know we don't have a date set up for next week, but you may have heard me mention earlier to the facilities that they won't have to attend, that we're working with you and DFA to maybe next Thursday or Friday try to set up a time where we can all get together and talk. So
perfect. That'd be great. And again, I wanted, on behalf of Mr. Abbey, to thank all of the facility administrators for coming and joining us for the working session with the Medicaid folks. That was very helpful, I think, and I'm appreciative of all the time and effort that took. And also, we look forward to this meeting next week to try and crank a little further and get some solid numbers along with DFA. So thank you all.
All right, thank you. And if there's no other comments or questions, I'm going to ask for a motion to adjourn to closed session. And in closed session, we won't discuss personal matters or any issues that need to be voted on. And we'll re-adjourn very briefly for a moment to open session after that. So if I have a motion to adjourn to closed session.
So move.
Second?
Second.
All in favor?
Aye.
Opposed?